Good evening, everyone, and welcome to this UEFA medical webinar. It's great to see many of you again joining us live. And whether you work in a club or a national team or in research or in clinical practice, you're very welcome, and your perspective matters for tonight's discussion. And tonight's topic is hip and groin injuries in football. These injuries come back every season in almost every environment, and they raise clinical questions, uncertainty, and if we're honest, a fair amount of frustration for players and staff. Hip and groin problems sit at what we believe the intersection of anatomy, load, performance, player care, that makes them important and inherently complex. So this session today is deliberately not built around a long slide deck. Instead, we'll use this hour for an open, honest conversation and discussion grounded in the decisions that you face with players. Our aim, as usual, not to offer a single protocol or a one-size-fits-all checklist, but to explore what we know from research, what we see in daily practice, and how these injuries are managed in real football environments. And this applies also in this case for both men's and women's football and across different levels of the game. So we'll try to highlight where experiences or management considerations may differ, and you're very welcome and encouraged to submit questions throughout the session using the chat. And I will keep an eye on them and bring them into the discussion where they will naturally fit. So please don't wait until the end to share your thoughts or dilemmas. Just put them in there. Before we start, just a few moments of your time to think about something. So before we jump into our first case, we have a few cases prepared. We really like to hear from you in the chat. Just type your answer to this question in a single word or whatever. What is your biggest challenge with groin injuries? Could be diagnosis, could be rehab progression, return to play decisions, prevention maybe. Just type it in the chat so we can use that as a prompt for the discussion we have with our experts today. While you do this, and let me introduce our panel for tonight. We have Gwenaelle Pelé from PSG. Hi, Gwen.
Hi.
Could you
Hi,
join
everyone.
us?
Thank you very much for the invitation.
I can see you on the road, so I'm really happy you found the time to be with us for this hour. Second up, we have Enda King from Espetar, who at the moment is in Ireland. Happy it's not raining anymore, I just heard.
Absolutely.
Hi, Enda, welcome.
Thank you. Good to be here.
And we have Josh Heerey from La Trobe University, who is a really early morning for him. Thanks for joining us, Josh.
No problem. It's great to be here.
Cool. And before we start with our cases, a few open questions about hip and groin injuries in football. Maybe I can start with you, Josh. I got you on the screen last, but maybe the first question directed at you. If we talk about the magnitude of the problem of hip and groin issues in football, can you say something about how common is it? How severe are they? What are the performance limitations? Just to give us an overview of what we're actually talking about.
Yeah, it's a great question. I think probably in the last decade or so, we've realised that the problem is bigger than we probably initially thought. We know that a lot of players suffer groin problems and may not always be restricted from mistraining or games, but they are affected in their I suppose their daily performance, and that goes throughout the competition season. And they often come into a season having sustained or experienced groin problems in the previous season, which predisposes them to, I suppose, future groin problems. So I think the problem is a massive one in sports medicine. And if we we can work together as I suppose a multidisciplinary team, then we can often effectively manage these problems.
Okay. Enda, can I ask you a brief follow-up question on that? So it is a problem. It's something that comes back. We just heard from Josh. But when you see a player who has recurrent pain, what's the first thing you're thinking about? What jumps out in your mind?
I think you're trying to, I suppose, ascertain why it hasn't worked out well the first time. And there's obviously three drivers of that. Number one is perhaps diagnostic, which isn't easy, no matter where you work or what you have available to. And we'll probably discuss that in a while. And number 2 is rehabilitation. Perhaps I missed some of the key components about why that groin became overloaded. And then number 3 is probably reloading, in that I can get the right diagnosis and perhaps be on the right rehabilitation pathway. But if the demands of the season, or perhaps player expectation or urgency, means that you get back into full playing and training, or perhaps before your pains has settled, or you're rehabilitated fully, then any one of those 3. And so it's very important that we understand what the driver is if we're going to have a better outcome second time, rather than jumping around the various causes of potential repeated recurrence.
Yeah. Thank you for that thought, Gwen. You work in a team, so you treat this on the pitch. When the word recurrence comes into play, what is your first thought as an actual practitioner on the field?
Yeah, actually, I'm working with a female player, so I think it's a little bit less a main problematic for us, even if it's a big problematic for everyone in a team in a soccer. But I think what we said before is very important to say. That means that it's important to try to identify why the pain is occurring, because it's often multifactorial, and it's often difficult to find why there is this kind of pain. And I think the main thing also is to have the confidence of the player, because they often try to hide a little bit their pain, because they want to pursue to train and to continue to train, because the games are arriving, and it's important. Games are arriving all the time. So it's important for us to have the confidence of the player, because we need to work with them in this case, in sort that they can tell us what they feel, and we can manage the load all the time to be the more efficient as possible.
Great. So I think that's also one of the questions already that has been posted in the chat. Is the one of the issues is treatment and the complexity of rehab. So if we go into the cases, let's focus a little bit on that, because it's not easy, straightforward injuries. No injury is, but this one is a little bit more complex usually. So that's good. So let's just dig into it. We got a full hour. We got 3 cases prepared. So let's focus on our first case. And just to highlight, these are all imaginary cases. These are not real cases. This is a random picture of a football player. So whatever is on this slide is not the football player you see on the picture. Let's start out with a winger who never gets quite over his groin issues and pain. So just as a short background, while people are reading the slide, we have a 24-year-old professional player, a winger, and he suffers from gradual onset proximal adductor pain in the preseason after the jump in high-speed running and crossing exercise. The treatment here was brief relative rest and manual therapy. He returns after 4 to 5 days, reports recurrent pain, has now missed 3 matches, and never feels quite right in accelerating or striking the ball. So I think that this kind of highlights the complexity already. So just to get the discussion started, whoever wants to take this question on the screen, go for it. What is your first working diagnosis and key differentials you must not miss in this case?
I'll take the hit for the team then. So in that regard, the description is very, very common, really. Coming back into pre-season, there's obviously been a change in load from perhaps a period off and back in again. Not exactly a young player, probably a player that's had a few seasons under their belt at that stage. Just listening to their signs and symptoms, it seems very much mechanical in that, gradual onset, a brief drop in symptoms with rest and manual therapy. But then as their loading comes back again, they redevelop their symptoms. Given the fairly pointed nature of the proximal adductor, you'd imagine, and this again is where the difficulty is, that there can be either a proximal adductor or pubic bone or a combination of factors attached to it. You'd be unlikely to think the inguinal region just by the fairly localized proximity of symptoms. And certainly that's something that should be then reproducible on your pain provocation tests and palpation tests, whether you have radiology or not. But I think the key thing initially would be to, if their symptoms are not resolving, is to just confirm that it's a diagnosis that you feel is either for rehabilitation or requires something else. And then if it is for rehabilitation, when you look at the early management, is it that the acute episode, or not even the acute episode, the onset of symptoms hasn't had long enough to settle down? It's really only a couple of days. Or has the underlying factors that have led to this gradual onset not been addressed? And that's why after 3 matches, they're perhaps still not getting to where they need to go.
Anyone else wants to react to that?
Yeah, I totally agree with Enda, and also I would say like it's the pre-season time. I think it's important also to refer to the assessments we did in general in the club. We are doing a pre-season assessment where we can see all the mobility, all the strength assessment and everything. And I think it's important to see if there is a decrease on the performance of the player on all the pre-assessments we did already before. And with that, we can also try to have a new strategy, maybe also to compare what is done, during the training and everything, to see if the load was correct and everything, if the loading was enough progressive or anything, and to try to change little details on that to try to have a better efficiency.
Yeah.
Yeah, but I would agree with Enda and Gwen. I think for me, this presentation would suggest adductor-related groin pain. And I think, as Gwen nicely mentioned, I think it's really important to understand what measures and metrics they're using to guide this return to play, because often these measures aren't used, and we need them to be able to determine when the person is ready to return to training or match play. So I think that they're really key points.
Yeah, we also got 2 questions on that in the chat already. But before I go there, before you treat, probably you want to have some objective measures. What are the objective measures you would actually use in this case to get a little bit of a better hang of the symptoms and potentially the underlying causes?
I'll start. I think the adductor strength is probably one of the key measures here, given the location of symptoms and what we're thinking the clinical entity may be. So I think understanding, and you can obviously capture those measures using dynamometry or other objective strength measures. I think that's one of the key things I would be looking at this stage. And then, as Gwen nicely mentioned, to compare that to their potential. Hopefully you've got pre-season or before injury data to be able to compare to. And that would be, I think that's one of the main things I would be looking at this stage.
Yeah, and actually, if I can add something, sometimes we focalize only on the analytic strength of the adductor, and sometimes we forget a little bit the endurance, the strength endurance, because sometimes the player is able to have a great level of strength on 1 or 2 repetitions, but when we try to do it for several repetitions, we can find a lack or difference in balance between the right and the left or anything. So I think also doing some strength endurance with dynamic Copenhagen long lever or anything where we can measure the difference between right and left, or maybe comparing to the pre-assessments in the start of the season is important also, to because sometimes it's a lack of strength in endurance, not only in analytic strength.
Oh, absolute strength, endurance strength, and also a bit of mechanical function here. I heard from Josh. Highly debated squeeze test. Is that something people should consider in this case as well?
Yeah, it probably depends on what you have access to as well. Like there's obviously several different ways you can collect the adductor strength. I think the main thing is to make sure you're using the same test and to understand the limitations or strengths of the test that you're using, and have if you have several different staff that are collecting the measures, make sure that everyone is doing the same technique and procedure, because those variations can really change the values that you're getting with your testing.
That's a good point to make, I think, Josh. Yeah. Now moving to the rehab. There's two questions in the chat based on, I think, your initial description of the case. The first one is what manual therapy would be the most appropriate, or is that dependent?
Yeah, I think I can comment on that. Manual therapy is not inappropriate. Certainly as a way of reducing tone in the adductors, and for some short-term symptom relief. I think it's likely, and in this case, even though it's just a made-up case, it's unlikely to be successful because it probably doesn't address the reasons why that adductor region has become tonic or overloaded in the first place. It's very much a gradual onset of symptoms, even with the spike in training load. And so if that tone or that symptoms is driven by a lack of strength or endurance, as the guys have highlighted, it's highly unlikely that manual therapy will, as I said, is not inappropriate, but it's unlikely in and of itself to address the underlying factors. And certainly there's lots of groins that get better despite no manual therapy, but it's unlikely they get better only with manual therapy. So you can add that as dessert as you see fit. And just add as well to what the guys were saying there, I think there's two challenges in the assessment in a groin like this. Number one is, especially after a couple of weeks, it's difficult to ascertain what was there before the pain started and what was there afterwards, especially as they become deconditioned. Often they get lots of inhibition, whether that's trunk muscles, proximal, distal, etc. And the second one is, especially if your squeeze tests are not only a measure of the ability to produce force in the frontal plane, but they're also very, very good pain provocation tests. And that'll be very important for mapping your return to run, return to jump, return to train. But also it can be difficult to ascertain what's true strength deficit versus pain inhibition. So that'll really, those tests will probably start off life as your pain provocation tests to track that the athlete is responding properly and making good decisions. And then it may only be when they're pain-free you'll get a truer representation of what are real strength deficit. But again, it depends very much on the presentation and the test that you're doing.
Yeah, I think I'm not sure if it was a question or a comment in the chat as well by Ernest Paul or Paul Ernest, that a combination of factors contributing to pain makes the rehab already complicated. And I think that's just what you said, Enda.
And even with the aggravating and easing activities, and it'd be good to get Gwen and Josh's take on this, is that when they talk about high-speed running and crossing, is it that their pain is in the swing leg when they're kicking and crossing, or is it in the stance leg? Because your understanding of what the driving mechanics are, if it's when they go to push off or when they plant their leg for sprinting and kicking, or worse in the swing leg, the number of athletes you'll maybe see with an old injury on the contralateral side, maybe ACL, syndesmosis, etc., and that's contributing to the pattern of overload in their groin. So obviously you need to do a very localized assessment, but also then more broadly understanding, and this feeds in probably with the complexity of it, is it more the standing leg or the swinging leg, or how are they interacting with each other to result in that overload?
Yeah, I think that's a great point. And I also think that it also depends on potentially the time of game as well. Like, is it straight away when they're playing, or is it when they're fatigued and tired at 75th, 90th minute? So I think, as Enda really nicely highlighted, that the level of detail you need in these athletes is quite high to be able to tailor your rehabilitation and your advice and education to them about their training and rehabilitation.
Yeah. And attached to that, there's two questions in the chat. I will go to those later, but I want to focus a little bit on the rehab still while we are there. If you had to choose, like, say, 2 or 3 rehab priorities in this case, where would you put your money? Oh, quiet.
Yes, I think first of all, it's of course the adductor strength. We have to focus on that to try to rebalance. But I think we have to put it in the whole context. That means we need to have a big coordination between all the muscles who are involved. That means transversus. That means psoas. That means all the picture. We don't have to go only on the adductor, but I think we have to monitoring this and to try to to normalize as fast as possible this strength on the adductor, and especially in eccentric way, of course. And after we have to go on the load management on the pitch. That means that it's important that the player continue to train. We have to go to follow the data and to have some specific data that we want at minimum that he go through during the training. And for that, I think that we have some special, of course, GPS or anything are very important for that to have the data. But I think we have some device like a player maker or something like that we can use to have the volume of kicking, the volume of passes, and the intensity of everything. So that means a good measure to have a good level of solicitation.
Yeah. Well, that's a clear answer. But there's no but. I think there was also a question in the chat that relates to this: is which modifiable risk factors do you consider to be more accessible and more relevant to measure? I think you partly answered that, Gwen. And now here's a but. But this play is a striker. Is there any specificity in this play being a striker that you consider when you plan a rehab or a return to play pathway, or is it just general?
No, of course. I think we have to be very specific on every position of each player. The solicitation on the pitch will be totally different if you are a winger, if you are a striker, or if you are a central back. So I think during the rehab, we have to orientate our rehabilitation. And I think for a striker, the shooting part is a very important part. So we have to also to prepare the player for that. And so that's why we have also to identify when the problem occurs, if it's in the swing phase or in the stance phase, like Enda said, because I think depending on that, we will more have a focus on the stabilization of the hip and the pelvic part, or we'll have more a target on the velocity and the speed of contraction of the muscle. I think it's two different things and two different strategy in the rehab that we will change our strategy for the player, depending on the position, of course.
Yeah, the dependables, really, really good to highlight that. There's another question related to this, and maybe I'll throw you to the lines on this one, Enda. This person occasionally encounters pubic bone pathologies in cases like this. How would you approach decisions regarding training modifications and game participation?
Yeah, I think it's highly prevalent to have a number of different pain sources in these populations, and it's very, very common to have pubic bone edema in asymptomatic footballers and Australian rules players and other field sports as well. I don't think necessarily your management would change hugely from what Josh and Gwen have suggested, in that load management would be important, trying to bring them below the aggravating threshold while maintaining some degree of chronic load in what they're doing. It's much harder to stop completely and build back up again than it is to drop to a level where your symptoms are not getting worse. Much of the pathomechanics that aggravate the adductor also tend to aggravate the pubic bone as well. Probably a little bit more special attention to the hip in terms of motor control of the hip and how that influences stress coming across the symphysis pubis to the pubic bone as well. So your motor control around the hip, especially as a stance leg, is very important. But I think fundamentally load management, rebuilding them back up as their pain provocation tests improve at key landmarks, and then addressing the functional reasons why they become symptomatic in the first place. They are probably going to be the foundations of your pubic bone or your osteotus pubis management. I think where it goes wrong is we rest it, it feels better, and we go back training again, the symptoms come back because we haven't probably addressed the underlying pathomechanics, or we manage it with anti-inflammatories and injections when that's, the inflammation is almost more a symptom rather than the problem, and not necessarily addressing the reasons why that becomes why that's been the case.
Yeah, adding to the complexity of things.
Sure.
Right. Yeah.
Sure.
One final question to the three of you on this case before we move to the next one. If you see this at a team level, what should we stop doing and start doing to avoid this like almost ready and then back to square one pattern?
I think I'll take this one to start. I think and Gwen mentioned this earlier, I think having, as best you can, having measures in the pre-season period, probably to identify those people that are maybe coming into the season with some form of groin problem is probably one of the key things, because we know when an athlete is coming into the season with a groin problem, whether it be a time loss injury or some sort of niggling groin condition, then they are more susceptible in the coming season to have some worsening or different type of groin problems. So I think if we can identify the problems early, in particular in pre-season, I think that will help us a lot.
And for that, Gwen, back to you. That requires the same message around the team, right?
Yeah, the measure is very important because we have to compare all the time to see if the performance is not decreasing. Because if the performance is decreasing, we have to maybe stop or the player or adapt a little bit more the training. But I think the most important is try to avoid big load and low load. That means that stopping the player is not the solution. We need to always have a minimum of the solicitation on the adductors, on the pubic and everything. Because doing nothing, I think, is the worst thing. So the total rest, I think, for me, it's something that we have to avoid absolutely. And we need to have to identify the minimal threshold of solicitation we need to have for the player in sort is able to compete with the team. And if we can assess that we can do a little bit more step by step, it's very good because we are in the good way. And maybe we have to reduce a little bit if the symptoms are worse, but not to stop at all, because I think it's the worst mistake we can do.
Yeah. I think for the sake of time, we need to move to the second case, because we can talk about this for 2 hours, but we don't want to eat too much of everybody's time. And probably we'll get back to many of the points we already discussed, so the subsequent cases might be a bit easier. So the second one is the overloaded midfielder with pubic pain. And in this case, we have a 21-year-old female semi-professional midfielder, plays for a club, league and cup, has a 3-month history of central pubic groin pain, and which worsens after matches, and sit-ups and long passes and sprinting also aggravates the pain. She can start games but struggles to train fully midweek. So again, maybe for the group, if you read this, what are your main red flags, and when do you push maybe for imaging despite constraints?
I think for me the most important is to identify that there is no bone stress fracture or anything, because the pain is lasting for 3 months now. So I think it's a long-term history. I think the problem there is to see if there is no pain during the night or anything that could refer to bone stress fracture or anything. And after the biggest thing, it's to see how because she's playing in two teams, in different teams, and it's a big issue, because for me it leads to a lot of miscommunication sometimes with the staff and everything. So for me, we have to also to know all the context of the player. This is very important for me to have the history.
Yeah, I mean, I would agree with Gwen. I think it sounds very mechanical, but I think we always want to be mindful of non-musculoskeletal conditions that can mimic pubic or adductor groin pain. I mean, it doesn't sound like this is the case, but I think we should always be thinking outside the square a little bit with someone who's not resolving, or the symptoms aren't resolving. So that can be gynecological, other conditions that can affect the pelvis.
Yeah. But like there's an intricacy to this case, of course, right? She plays for multiple clubs, so there's a difference with the previous case. It's a woman instead of a man. Is gender in this case in any way specific to the case, or is that anything that sets you off in terms of?
I think Gwen could probably speak to this better than I could, but I think when you look at the combination of function, anatomy, and diagnosis. That if you're happy that you've cleared the more serious or sinister drivers, especially I think bone stress fractures or stress reactions would be the big one here. That then ultimately it's the combination of function and reloading. Again, young athlete, busy, I presume, if semi-professional, so playing thing, maybe has other commitments, multiple teams, and even listening to the symptoms, like there's a strong abdominal or trunk component to it. So sit-ups, long passes, sprinting, things that are very dominant and challenging on the anterior core, to give it a very generic, inaccurate term. So I don't think those weaknesses would be gender specific. I think you can have that in male athletes and you can have that in female athletes. So I think assessment, assuming that your diagnosis is something that's amenable to rehabilitation, I don't see anything here. Good hip morphology or near normal, whatever normal is. I'll get Josh to tell us about that. But definitely, I think that there's nothing there from a rehabilitation point of view that would be any different in a male population compared to a female population.
Okay, that's a good addition. Thank you, Enda. Gwen?
For me, the clinical picture is the same for men or for women. There is no difference between. But for women, we have to be very focused on some specific points, like red S syndrome or anything, because we have to prevent any specific female problem, like a problem of cycle of menstruation or something like that, who can lead to other problem like bone stress injury or something like that. And I think it's for that we must have a focus and to be very careful with women. It's not because of the clinical side, because for me it's the same thing between men and women, but because we can have some additional symptoms who can modify a little bit the picture.
Yeah, fully understand that. When can I slightly rephrase that? We shouldn't be more careful with the female player, but we should focus on different potential modifiable risk factors that we may miss. Okay, thank you. Okay, so another intricacy of this case is why we developed it is semi-professional, and usually the first case was a professional football player. This is semi-professional. Usually there's not the same resources available in terms of personnel, medical staff, sometimes knowledge or tools available. Considering that might be the case, what would your minimal level of requirements be in terms of tools and resources? What is a good enough rehab in this case, basically what I'm trying to ask?
I think having worked in an outpatient setting as well as an intensive rehab setting, the main challenges often with semi-professional or sub-elite is not necessarily compliance, but accuracy. So we've all given people exercises, and they go out and what they come back doing is not a first cousin of the exercise that left. So it's not necessarily that they're not doing enough or they're not doing the right stuff, but maybe not doing it the right way and not getting the adaptation that you're looking for. So I think if you're going to judge your rehabilitation, you're best judging it on have you changed what you set out to change, as opposed to has it been 3 weeks or 6 weeks or 9 weeks. Certainly as a review centre, we get to see lots of groins. They've done lots of work, they've worked hard, they've done lots of stuff, but have they changed anything, or have they changed the key things beside that? And the second challenge tends to be then load management, in that in an elite setting, GPS monitoring, loads and workloads are monitored fairly well, or at least in a semi-live environment. Whereas in a semi-professional, perhaps there isn't that level of communication with the different stakeholders, and maybe that level of accuracy isn't there, or perhaps you're either in the training or you're out, and there's a more dichotomous component to it, and load management and picking the components is often less collaborative with your injured population. So they tend to be the main differences or difficulties I've come across, at least.
Mm-hmm.
Yeah, I think I'll add to end there is that I think one of the key things is I currently work in an outpatient setting, so people are going away for 5, 6, 7 weeks by themselves with their sporting club. And I think one of the key things I always focus on is setting them up with some parameters guide their rehabilitation progression, whether it be pain measures or repetition maximum measures, and also for them to understand when their exercise load has aggravated them. So giving them some simple things that they can use to understand when they're ready to run again, or have they responded well to their running program. And there's a number of different ways you can do that, but one of the ones I often use is a simple squeeze test, where the athlete will maybe run on a Monday. They can use a measure of pain, whether it be 0 to 10. And when that reduces to a certain amount, then they may be ready to run again, as opposed to just saying run Monday, Wednesday, Friday. Or I think giving them some additional parameters to work with, I think is quite helpful often, especially in an athlete like this that is often guiding themselves with their rehab.
Yeah, I think I will totally agree with Enda. Just I think when you are at a semi-professional level or anything, you have to keep it simple and to try to do it, not trying to do it so fancy a program or anything. I think core stabilization, easy Copenhagen progression or anything, I think it's quite enough to start with when you don't have fully a gym completely very full or everything. I think to keep it simple and to do it great, I think it's quite enough to start.
Yeah, and because we focus a lot on the technicalities of the rehab here, but there's also still an athlete sitting in front of you. You need to explain them something about their injury. How do you defer a message about diagnosis versus prognosis? Because if you hear something like this as a semi-professional player, that might be pretty scary. How would you deal with that in a practical setting?
Yeah, I think. Well, sorry, go.
No, I was just going to say that I think it's education is really critical, because often they've come to you with a diagnosis they've either been given from another professional, or they've read online that they've got osteitis pubis or something like that, and that's obviously quite confronting for an athlete. So I think understanding what they've been told and what they think is the prognosis is really key, because that will set up the athlete probably for success initially, and then obviously your rehab is really important beyond that. But I think education is really critical at this early stage.
Yeah.
Yeah, totally. I think the education, I think, is the main point. You need to educate your player, because it will be a long-term prevention program. So they have to be involved. They have to be convicted in the program. They have to be sure and to know why they have to do that, and to do it for a long time. Because even when they will come back on the pitch with maybe no pain or no, they have to continue the work, because otherwise the pain will come back. So I think it's something they have to understand, that it's a long-term project. They don't have to give up too early. And I think it's the main thing they have to understand.
Yeah. And I think this answers one of the questions in the chat as well. How do you manage a player who's trying to play games but struggle to train? It's communication and education. I think that's what you just highlighted very well, Gwen. But I interrupted someone who was trying to say something.
No, I was just going to add to that. I think I'd agree with everything that Josh and Gwen has said. I think you can highlight to the athlete that pubic bone edema on radiology is very normal, and these injuries get better. So that's you're 2-0 up before you start, and like you find in most cases, pain is not damage. It's feedback that the balance between your load and your recovery is just at a juncture at the minute that needs to be resolved. So that's in the rehabilitation process. Pain's very, very useful. It just means I did a little bit too much today relative to what I can tolerate. And then, as Gwen highlighted, pain when I return is excellent, because it means I'm just beginning to lose that balance between my function and my loading again. And that's just an early warning sign that I can ignore and pay for a little bit later, or I can be proactive on it and make very small changes. And actually it rarely cuts into training and playing load. I think that's often the challenge we have with our younger athletes or athletes stepping into senior squads, is they develop low-level symptoms when it's really easy to get rid of them, but they don't say anything about it because they either don't want to be injured or they want to keep full playing and training load, and often they only present when they're very angry and very sore, which is fine, but ultimately it's more difficult to get rid of or to recover back to pain-free function then.
Yeah. You just said young player. I think that's a really good bridge to our final case, also given time. The final case we prepared is a younger player, a younger defender with deep hip pain. Just briefly, 19-year-old academy player, central defender, since 6 months, a history of deep hip groin pain, and that gets worse with repeated kicking and deep defensive positions. The player says that he's stiff after sitting, and prior X-rays suggest scam morphology. Performance is going down, and now there's a bit of a debate in the club whether we need to have conservative care or maybe an early surgical opinion. Yeah. Any first thoughts?
Josh, this is your baby.
Yeah, sure. I think this is often a case that I see in my clinical practice where the person's coming in, they've consulted with a surgeon that has told them they have a cam morphology. They may have tried rehab and it hasn't worked for them. So I think one of the first things I talk to my patients about is their understanding of the condition. So often they're really heavily focused on the cam morphology, which is something that we see on imaging, obviously, in athletes with and without pain. And they often think that the cam morphology is an acute response around their pain. So it happened around the same time as their pain came on, as opposed to a adaptation to exercise during adolescence that we know for most people cam morphology is. So I think enabling them to understand that's a really important thing, and that we often see the bone shape in people without pain, and that a lot of people with cam morphology will have intermittent symptoms but may not go on to develop osteoarthritis in later life. So I think they're probably some of the key things I would often discuss, because the cam morphology in osteoarthritis is often a major driver for someone to seek surgical care and not try rehabilitation first.
Yeah, I'd probably add to that. Josh has covered it very well. I think it's not unusual in footballers to find stuff on MRI in the hip. I think we want to be very sure that the symptoms are coming from the hip joint and not other structures, maybe iliopsoas, other structures around the hip. So that's where an intra-articular injection, but will be part diagnostic, part therapeutic. And if you didn't get a substantial, 80% plus change in symptoms, perhaps the hip joint is not the main source of symptoms, independent of what the radiology says. And then secondly, even if it is, how much of that hip joint irritation is functional, even with the anatomy that it has, whether that's playing and training load or motor control around the hip, and how much of it is a true anatomical issue. And certainly aspects of, if the pain is coming from the hip joint and there's loose bodies or other things evident in the joint, that's a separate conversation. But I think number one would be, is the pain coming from the hip? And then number two is how much of that is anatomically driven versus functionally driven. And that probably goes back to our previous conversation, is then based on our functional assessment, what would we like to see change? And once we've made that change, are we getting an appropriate change in symptoms? And if we haven't, in spite of good functional change, as opposed to I've done 6 weeks of rehab, that doesn't, I've been on a diet for the last 6 weeks, I haven't lost a whole lot of fat. So it doesn't necessarily mean doing it is the thing. It's have you changed anything? I think that would complement the diagnostic points that Josh highlighted.
Yeah, so that's a good overview of what helps you distinguish between hip-related pain or other problems. But in this case, then, if you get confronted with the potential decision to do a surgical intervention, which factors would most influence your opinion to seek maybe a surgical opinion? Maybe this is one for you, Gwen, because you probably encounter this every now and then with players.
Yeah, but for us, of course, we will try to avoid at maximum the surgery. We will try to have a very important work on the player to try to reduce the pain as much as possible, and to improve the performance metrics and everything. Of course, if we have a significant functional limitation, I think we will question the surgeon, especially in internal rotation. If we have a severe internal rotation restriction. But I think it's really rare for us to undergo to the surgery. We need to have a big deficiency in the performance and in the limitation of the rotation to go to surgery, or otherwise it's because we have other signs like intra-articular signs like maybe on the labrum or something like that, who will push us to the surgery.
Yeah, I think Gwen makes some really nice points there. I think the functional limitations often can be one of the key considerations, in particular internal rotation. One of the probably the extent of early arthritic change would also be a marker potentially. So that would be what we're talking about there is the degree of cartilage change and probably labral pathologies. If they're I suppose they're more progressed than what we'd expect them to be, then maybe we're considering a surgical treatment. Albeit we know that those things also exist in people without pain as well. So I think it's multi-faceted, but I think they're probably the two of the key things I think for me. But and I'll probably also add that it's probably the extent of their rehabilitation, like how much rehabilitation have they tried, what type of rehabilitation have they done. They're probably some of the key things for me.
Yeah, let's go to rehabilitation after my next question, because this is a 19-year-old player. Probably there's also some parents involved. How would you frame expectations with the player and in this case his family about the two, conservative versus surgical? Because they probably have ideas, or they Googled it, or they used ChatGPT to figure out what is best for their son or daughter. And then you sit there as a doctor or a therapist.
Yeah, I think a lot of that will come back again probably to the anatomical presentation. Both, and this is the challenge. This is a challenge for orthopods as well as those involved in rehabilitation and S&C, in that our surgical colleagues will say an isolated labral tear does very well with surgery, and we would normally say it does very well with rehab. So the extent of the extent of the damage or otherwise will certainly influence the prognostic discussion around it. If you've a certain amount of degenerative change on the acetabulum, especially on the femur, that's quite a compromised joint, and no surgery is going to fix that. And there's lots of research, especially by our Danish colleagues, to say that's not to be dismissive of hip arthroscopy, but the extent of which the hip has changed is going to have a big impact on that. So I think that would be the initial part of the conversation with the player and the parent, and that ultimately, regardless of and pending the success of the surgery, that rehabilitation will be an important part, and load management. It's not uncommon to get these probably incredibly talented young athletes, footballers who have played a lot through their adolescent and teenage period, hence the large cam morphology, usually a sign of talent that you've been playing lots through your teenage years. So load management and function is going to be an ever-present part of their decision-making afterwards, again depending on the extent of what they find after arthroscopy.
Yeah.
We have to speak about the future of the player. That means that yes, maybe the surgery can seem to be the easy way, because it seems that after 10 weeks or 12 weeks of rehabilitation, after we can go back on the pitch and we think that we're over. But if we, like in the pubic and the groin pain, if we don't find why there is this problem at the initial part, and why if we don't fix the problem at the initial part, we will have the same problem and the pain will come back again. So I think that's why it's important to have a big conversation with the parents to make them understand that the prevention and the rehab work is the main option for the player. And after, if we fail for that, the surgery has to come in the last position for the decision.
Yeah. And let's go back to the rehab then. So let's decide we stay conservative, because that's in general usually the preferred option. In brief, what would a realistic on-pitch progression look like in this case, you think? I know there's not much information on the slide and on the case, but let's just brainstorm a little bit about it.
I think one of the key things is to think about, even though we know that the bone shape is there in people without pain, but sometimes the mechanics can influence our rehab decisions. So for me, often then they're probably not going to tolerate a lot of change of direction running initially. So you may start with maybe more linear based running drills or passing drills, develop their tolerance that way, and then slowly introduce change of direction or drills or match play. I think that's probably where often we go wrong, is we start doing that too early, and they haven't either developed the movement competency or the strength or endurance to tolerate that type of movement yet. So for me, I think linear, but like straight line running type activity would be probably the first thing I would attempt. Yeah.
Now, there's an interesting question, still going back to the surgical options in the chat. What would be the minimal amount of time for adequate rehab before you go for a surgical opinion?
I think the surgical opinion would be, often what happens before surgical opinion is that the team physician or the sports medicine doctor will have done some preliminary diagnostics, may have facilitated an interarticular injection. So I think the first thing they'll have ascertained if the joint is the source of the symptoms. I think secondarily then the functional menu you come up with in terms of where you think there's areas for growth for that athlete. And that can often be, if that's addressed quite quickly, there's no need to string out the referral just to give it its 3 months or 6 weeks or whatever else. I think very, very quickly, if you're sure the pain is coming from the hip and you've made good functional changes or those minimal functional changes to make, and they're having ongoing symptoms, I mean, it's better to get that opinion earlier. Whether they do something or not is secondary, but I don't think you need to give it X amount of time if ultimately the joint is the driving factor.
Yeah, I would agree with Enda. I think you need to be really honest with your athlete early. We often say 12 weeks because that's what guidelines recommend, but I think you would know relatively quickly whether your approach is going to be effective in the athlete. I don't think you need to prolong it to 12 weeks because that's what the guidelines say. I think if you're not seeing improvement with everything you've tried and they've had an intra-articular injection which has had a positive outcome, then I think that then you can start having discussions around surgery.
I think again, given time, we discussed this case enough. There's still 2 loose questions in the chat that I like to throw at you before I will ask you a final question. So let's get the case off. We talked about pain and the complexity around pain because it can have different sources. And one of the questions in the chat is does rehabilitation differ greatly based on the different types of groin pain? So does finding the pain source really alter your protocol, or is there some kind of red thread anyway?
I think I'll comment on that first. Personally, it doesn't, for a couple of reasons. At least in my experience, I would greatly struggle to say that, if I had adductor-related groin pain or pubic-related groin pain, we see the same functional deficits in them all. We don't there tends to be a lot of variety, especially in athletes presenting with multiple entities. And the danger is you give everyone the same program, and that's what some athletes need. It's a little what some athletes need. It's not what other athletes need. And certainly previous work I was involved with in Dublin suggested that the duration of symptoms that you've had your symptoms or the diagnosis that you had didn't influence your pain-free return to play. So I think trying to identify the individualized functional components and then obviously individualize the some athletes respond to reloading quicker than others or slower than others, as the case may be. So I think those 2 factors are very individualized and seem, at least in my experience, to be very independent of the diagnosis that an athlete has.
Yeah, and I think if I can add, I think the rehabilitation will change more by the position of the player and the demands on the pitch. What's the position of the player? If it's a goalkeeper or maybe a striker or something like that, we will of course change the rehabilitation more than the diagnostic at the beginning, at the start.
Yep, there was Josh.
No, I don't have anything to add there. I think Gwen and Enda have answered that really nicely. So
yeah. There's now one other question popping up, so I want to put this on as well. With such a complex groin pain case, has anyone of you tried to manage that through a congested fixture period with load management, but the symptoms are still there? When do you take the decision to pull them out? A very practical question, I think.
Yeah, I think that's a I don't think we have the answer in terms of from the science, but I think it's a problem that we all face at some point. I think the decision to pull out often comes around their performance as well. Like if they're not performing and tolerating game loads, then something needs to change there. And it may not be that it might be they're having reduced game time, or varied training loads, or they're reducing particular training drills that might be aggravating them. I think it's often a dichotomy, train, no train. I think it may be more somewhere in between, and trying to find out, I suppose, the perfect balance for that athlete to keep their hip and groin happy would be the key. I don't have the answer to it, but I think that's probably what we're trying to aim for.
Yeah, I think to add to Josh, there is no one right answer to it. So I think that the stage of the season probably comes into account a little bit as well, in that the decision might be, are we looking to resolve this groin issue, or are we looking to manage it? So if you have a couple of games left in the season, perhaps Champions League final, if you're playing with PSG, etc., the chances are you'll try and find some way of getting through it, perhaps with some analgesic support through that period, knowing that a period of rest and recovery is just around the corner. If the athlete's struggling in the middle of September, it's highly unlikely they're going to get to Christmas, let alone to the end of the season, without a period of resolution, especially if some fixture management has not already resolved the symptoms. So I think if it's quite angry earlier in the season, your hand is going to be forced a little bit quicker as well.
Yeah, and I think it's also communication with the technical staff, with the player, and I think it's communication where we need to have with all the protagonists of the story. That means that the player is involved, the coach is involved, and of course the medical staff. And after, it's a big decision that we make together, because or the player or the coach will say, okay, I'm not, I can't perform anymore at my level, and it's annoying for me, or it's annoying for the team, or anything. And I think it's the main thing will make you down the player a little bit outside of from the group or anything.
Yeah.
The one I just like to add one.
Yeah, just.
Great mention. I think for me, working in an outpatient setting, it becomes very challenging, because often you're not in the team environment. So I think as best you can, having conversations with the people that are involved in the athlete's care, even remotely, will be really beneficial. It's very hard to do that sometimes, but I think that is one of the key things for success in an athlete.
Yeah. I'm sorry, but because of time, we have to leave the last few questions that just popped in hanging. We'll try to answer them separately, no worries. But before we close, I'd like to ask the three of you a really brief reflection. Let's step back and just I have two questions for you, but answer them in one sentence. One thing you would wish teams would stop doing when managing groin injuries, and one thing you wish they would start doing instead. Give you 10 seconds to think, but maybe Enda, I can start with you.
Yeah, I think one thing I'd like them to start doing is identifying earlier who is symptomatic, and having an open communication with athletes. That presentation of symptoms doesn't mean you have to stop training, but flag it early. It's easy to manage, and I'd like to stop them just doing only isolated strengthening, especially the adductors, as a way of preventing overload in the area. Not that it's not effective, but it's often one pill when it's often a little bit more complicated than that.
I think one thing I would like them to start doing is and we talked about it tonight, is education around imaging findings and the relevance, and how they are seen often in athletes with and without pain. And I think one thing which they could add would be, I think, as Enda has nicely put it, I think a composite rehabilitation would be probably a key target, I think.
Yes, and I would say all of this, and of course, stop thinking only on adductors. And I think it's a more deep picture and everything. And we have to speak about deep muscles and stabilizers muscles. I think it's very important also, and to don't forget these muscles, I think.
Understood. I think the quick summary of all that is that managing hip and groin injuries in football is not about rigid rules or one size fits all solution. It's about listening before you act, and especially also adapt care to context. I think that was pretty clear from the discussion. So thank you very much for your discussion, and also thank you very much for the people online who joined us and asked questions and contributed to this discussion. We do hope that this helps you in your approach with the next one case with a little bit more structure, confidence, and clarity. Now, before we all log off, a quick shout out for our medical symposium, UEFA Medical Symposium, February 2 to 4, 2027. So there's a bit of time ahead, but please save the dates already. It will be in Dublin, home ground for Enda. More information will follow soon also on these webinars. So please stay tuned. So all that's left for me is to wish everybody a good evening, our speakers, but also our participants. Please join us for the next webinar, Monday 30th. And this may sound a little bit like a curveball, but we're going to talk about concussion challenges in para football. And that is a little bit more complicated and complex than you would guess at first sight. So hopefully see you there, and have again a lively discussion with international experts, and have a great evening.
Thank you.